So thank you very much. I would like to apologize on behalf of myself. Okay. Sorry, I don't know if everyone can hear me. So apologies, please. I tried getting over so many challenges here. So I have about 4 or 5 devices and they're all messing up. So please, sorry for that. And just like a side comment, I discussed with Professor J. Rahman. Some of us know him. He's a very wonderful teacher who, of course, has some other things to do, but he promised he would join us along the course of the presentation. So, yes, the topic we are going to be presenting today is acute upper gastrointestinal bleeding, an overview. We chose an overview because after a deliberation with so many members of the Doctors Assembly platform, we concluded that quite a number of persons would be requiring basic information rather as general practitioners rather than a specialist. So we would not bog you with unnecessary details. We try to go straight to the point and what we think is applicable to everyone, at least as regards the topic. So I just to pick at the end of this presentation, number 1, identifying upper gastrointestinal bleeding. 2, identification of the various causes of gastrointestinal bleeding, upper in this case, and of those causes, identification of the commonest causes of upper gastrointestinal bleeding. Then a general approach to upper gastrointestinal bleeding, because this is really causing a problem, even in the tertiary institutions. There are so many problems regarding who owns the patient, and whoever is seeing the patient first does not realize that he also has a role to play in the management of this patient, vis-a-vis reducing the chances of rebleeding, chances of hospitalization, surgery, and the ultimate price of death. And then I also want us to identify the limitations of management, which I was just trying to explain earlier, and then possible solutions to identifying some of those limitations and doing something about it. So as a form of introduction, I would like to define upper gastrointestinal bleed as any bleeding that occurs in the gastrointestinal system proximal to the ligament of Treitz. The ligament of Treitz is where the duodenum ends and the jejunum starts, also known as the duodenojejunal flexion. So any bleeding from there, from the mouth to that point, is upper gastrointestinal bleeding. The presentation can vary. It can be very trivial, and it can be massive, requiring resuscitation and other aggressive forms of management. If we are to consider gastrointestinal bleeding as a whole, upper gastrointestinal bleed accounts for 80% of all gastrointestinal bleed. And it is often said at times that the commonest cause of lower gastrointestinal bleed is upper gastrointestinal bleed. So it accounts for about 80% of all gastrointestinal bleed. To put this into numbers, about 100 to 170 per 100,000 adult hospital patients would present with upper gastrointestinal bleed. Now, about 85% of these patients, bleeding will stop spontaneously. But that is not just good news. It is do we know what to do when this bleeding stops? Or do we know what to readily think of? 1, for every patient that has spontaneous resolution of bleed, there are possible outcomes like 1, complete resolution, 2, risk of rebleeding, and then 3, there could even be other causes that require urgent attention, and the bleeding is just a way of flagging down that this patient may be in danger. And then of the 100%, we said it's 5 will have spontaneous resolution, 15% will have persistent bleeding, and of this, total number of persons that would require surgery are just about 5 to 10%. So you may want to say, oh, does it mean that other patients can be managed medically? If you use medical as a loose term, well, yes. But if we are to be very specific, we would say no, because there is actually medical and then endoscopic management, which also plays a very important role in arrest of bleeds in these patients. Usually, the patients that would require surgery are older and sicker patients. Management of these patients is multidisciplinary. It's one of those problems we earlier highlighted. Who owns the patient does not really come to play, but what the patient is presenting with is going to dictate who gets to manage the patient and then to what extent. Now, the causes of upper gastrointestinal bleed, we can classify them broadly into non-variceal bleed and variceal bleed. Non-variceal bleed, again, accounts for 80% of the total number of cases, and variceal bleed accounts for 20%. The non-variceal bleed, we have the peptic ulcer diseases. It could be gastric, duodenal, malware. Of course, peptic ulcer disease accounts for about 30 to 50%, an average of about 40% of cases. So it's taking a large chunk in its own category of non-variceal causes. Malware, depending on the type or your reference, could account for another 15-20%. Gastritis, duodenitis, 10 to 15%. Then esophagitis, malignancy, and other causes. I wouldn't bug you with the list of other causes, but we can just say give hemosorcus pancreaticus and the likes. Of course, malignancies too can come into play, Delafoy's lesion. And then for the variceal causes, these are usually as a result of portal hypertension. In most cases, patients have a CLD, chronic liver disease, or cirrhosis. And it could be in the form of gastroesophageal varices, which accounts for about 90% of cases of variceal causes. And then portal hypertensive gastropathy, about 5% or less, and then isolated gastric varices. Now, what concerns us mostly is what I'm going into. How do we approach these patients? How do we approach these patients? So thank you, control room. Approach to patients. Yes, I just made this up anyways, using the acronym REST. We want to rapidly assess these patients and assess if the patient is going to benefit from one, admission for inpatient care or outpatient care. And if the patient is going to be admitted, the degree of resuscitation. History and physical examination would help hone down to how much we need to aggressively resuscitate this patient. From the history, we've got the fact that this man had about 500 mils of vomiting of flank blood, had about 3 episodes, had reduction in urinary output, and had syncopal attack. From the history, you already know this man has lost quite a number. And therefore, the physical examination would like to check for some things that may be suggestive of what the cause is: ingestion of non-steroidal anti-inflammatory agents. Patient has been having recurrent epigastric pain in the past. Patient abuses non-steroidal anti-inflammatory drugs, or maybe an elderly person who, an elderly person who perhaps has arthritis and then is abusing non-steroidal anti-inflammatory medications, or you could just see some signs of chronic liver disease, primary erythema, jaundice, ascites, spreader and the likes. So those are the things we want to do. So in the assessment of this patient, after assessing the patient and we have come to a conclusion that this patient will need inpatient care, we want to start resuscitating. Resuscitation of this patient and other physical examination go hand in hand. You don't wait for one before you do the other. And it's basically about the ABC of resuscitation. Airway, is it patent? Is this patient bleeding? Does this patient require immediate intubation? In cases of maybe massive variceal bleed, you could immediately decide that this patient will be an ICU patient and will require intubation. You want to assess the hemodynamic status. Number one, even if you have not come to do your PP and every other thing, this person has postural hypertension, the patient is agitated, tuned, there's reduction in urine output. You already know this patient has lost at least 40% of total blood volume. Or this patient has changes, maybe a drop of blood pressure more than 10 millimeters of mercury in the standing position from a sitting position, or there is increase in the pulse rate by more than 20 beats per minute. You know this patient has at least 20% of total blood loss. And well, of course, it's worthy of note that some of the patients, maybe who are elderly, may mask some clinical parameters, especially those on a beta blockers for other comorbid conditions. So the next most important thing that we'd like to do is risk stratification. It is very important that regardless of the cause of bleed, resuscitation, until proven otherwise, is the same. It's the same. Still the ABC of resuscitation is what we're following. And then for the risk assessment, what do you need a risk assessment for? And this has nothing to do with you being a surgeon, a physician, or an emergency specialist. It just has to deal with the fact that you are the first person contacting this patient as the first responder. So the risk stratification is important to predict the risk of rebleeding in this patient. 2, need for further evaluation, length of hospital stay, and then mortality. The risk assessment stratification can be based on just endoscopic findings. This next slide. It can be based on just endoscopic findings. It can be based on endoscopy plus clinical parameter. It can also be based on a clinical parameter. Some examples are listed in the slide. Endoscopy based is the popular Forest classification. It classifies patients into 6 categories. So between category 1A and, okay, thank you. Between category 1A and 2A, the patient is going to need an endoscopic procedure. Simply put, you put an endoscope and then you see any of this, spotting bleed, or some would say arterial bleed, oozing bleed. This 1A, 1B are active bleeding, but one is arterial, the other is venous. Arterial is spotting or pulsating bleed. Venous is oozing. Or you come across a visible vessel, though not actively bleeding. Remember, the acidic environment can still erode on this. You need to do something in these 3. You need to do some forms of endoscopy therapy. And then these are classified as high risk. High risk, 1, 2, 3, classified as high risk. For the 2B adherent clot, what you have to do is you try to flush this clot and see if you can dislodge it. And whatever you see under is going to determine what next to do. It is the intermediate risk. And then for 2C and 3, they are called low risk. Chances of rebleeding, as you can see, 7 to 10, and then 3 to 5%. So those ones don't need endoscopic treatment. So the Forest classification actually was designed to predict the risk of rebleeding, but it has also been shown that, obviously, from what we just described now, that it can dictate the next line. Do we need extra intervention, which the endoscopic findings will tell us in 1A to 2B, and it also predicts the risk of need for surgery and then mortality. Sorry, also worthy of note is that Forest classification is largely based on non-variceal bleed. Then can I go to the next slide, please? Yes, this is the Rockwell scoring system. The Rockwell scoring system can actually be used as a clinical system alone, or as a clinical plus endoscopic risk stratification system. So for the clinical Rockwell score, I think it was 1996, if I remember, what you need is the age of the patient, the pulse rate, and the systolic blood pressure, and then any comorbid conditions. So you can use this in places where endoscopy service is not available. But it tells us something. If you have a score of more than 2, then perhaps this patient needs an endoscopy. Now, if you then get an endoscopy, it will tell us, is it due to varices or other diagnosis? And then if we can identify the lesion, you then go back to what you saw in your forest classification. What type of lesion are you seeing? Is it the one that requires an intervention or the one that does not require intervention? The next slide, please. Yes. So this is the Blatchford scoring system. It is based on clinical parameters only, like you can see here. There is, sorry, I forgot to mention that any score of more than 8 for the Rockall means high risk for prognosis. So for the Blatchford scoring system, I think we need to know this because it's all about clinical stratification. We try to add up. The maximum score a patient can have is 23. The higher the score, the higher the risk of bleeding, higher the risk of surgery, and then mortality. Other scores that are simpler, that use the clinical parameter only, include the AIMS-65 score, AIMS, AIMS 65. The A is for albumin, less than 3.5 grams per dl or more than that. The INR value stands for the I, anything more than 1.5. The M is mental status. Is there alteration in mental status? The S is systolic blood pressure, is the 90, and then the 65 is just the age of the patient. So by the time you start having quite a number of these, then you can classify your patient as high risk, and then what you'd want to think of next. Vis-a-vis need for endoscopy, need for admission, need for blood transfusion, and prognosis regarding outcome in this patient will be very important. Another score is the T-scoring system. So yes, of importance, just like I was trying to say, is the forest, the Rockall, and then the Blatchford. So there's also another classification system that is known as the BIT classification system. It's a bit of the AIMS score, where you take cognizance of the systolic blood pressure, the INR, the altered sensorium, and maybe the patient has a comorbid condition that would require ICU care. So it is also known that a patient who is on admission for another thing and then develops upper gastrointestinal bleed has poor prognosis. Something must have kept the patient on the bed in the first place. So it's like a sick patient having another sickness on what earlier came with. So this could also predict mortality and morbidity, with comorbid conditions, persistent hemorrhage and infarction. Next slide, please. Now, for the resuscitation, like we earlier highlighted, inadequate resuscitation, either at presentation or subsequent resuscitation, inadequacy leads to death from multi-organ failure. In other words, these are not the patients that will say, oh, the bleeding has stopped and then we move to the next patient. No, they need reassessment of their status. Because the patient may be well now and then bleeds again and then goes back to what we call square one. Fluids, very important. We know the patient is losing blood. By principle, you replace what is lost for what is lost, blood for blood. But before grouping and cross-matching, ideally takes about 5 minutes to 1 hour. You want to give 2 liters of Ringer's lactate in adult patients with no comorbid conditions, no heart failure, and no fluid retention. You want to take some basic investigations like a full blood count, checking the hemogram, which is more important than the fat cell volume. You want to check the platelet count. You want to check the liver function test in this patient and assess the risk of coagulopathy. The INR is very important in this patient as well, and the blood urea nitrogen for the electrolyte and creatinine. So we also want to monitor these patients for two things. One, is there a response to fluid correction? There are some patients, maybe young patients, no comorbid condition, lost about, let's say, 25% of total blood volume, with good response to fluid resuscitation. Such patients may not require blood transfusion. Actually, the Park cell target volume could even be as low as 20% in such patients. We also want to monitor for adequate tissue perfusion. Urinary output monitoring is what we can do bedside. And then for elderly patients with other comorbid conditions, we want to monitor the central venous pressure. And then assess for possible ICU care. And then the need for blood transfusion is based on many factors. Like we earlier said, how much has the patient lost? Is the patient still bleeding? Is the patient elderly? And is there response to fluid therapy? And then in the history and examination, what we said earlier, magnitude of loss, possible etiology. For PUD, we want to check if there's history of recurrent epigastric pain. Has there been an endoscopy in the past that confirmed PUD? Also, other inflammatory drug abuse. Binge drinking with relching suggests malarious, and then patients with maybe chronic hepatitis B, not regular medications, now presenting with ascites and massive blood loss with testicular atrophy in men who suggest chronic liver disease, and then you want to think of variceal bleeding. Now, the next thing we want to do is we've resuscitated this patient. We have tried to pinpoint an etiology from the history and examination, but it does not suffice to say that we can get the source, or what we call localization of source, without at least two things. Nasogastric tube placement, upper GI endoscopy, which is actually the gold standard. For nasogastric tube placement, some say it's controversial that you may not want to use it in patients with variceal bleed because it can provoke bleeding. But it has been shown as well that there are some other benefits, even though that even reason is relative contraindication is not absolute. Number one, with passage of NG2, you can be able to immediately confirm or at least rule out the source of your gastric bleed. If you have blood coming through the endoscopy tube, is it fresh blood which may suggest ongoing bleed? Is it coffee ground blood which could suggest old bleed? You can also use it to decompress the stomach. It would also serve the advantage of emptying the stomach of blood in preparation for an endoscopy, which would enhance your view. It can also be used to lavage the abdomen and dilute the acid, which has been known to be fibrinolytic. And as such, diluting with your lavage would perhaps give an advantage of preventing fibrinolysis and clot dislodgement. Of course, you can pass the nasogastric tube and it will come out as clear flames, despite patients having upper GI bleeding. This is because the bleeding occasionally could be from the duodenum, and with an intact pylorus, your NG2 flame will come out as clear. Meanwhile, the bleeding is from the duodenum. So that only tells us more that the need for an upper GI endoscopy is still important, despite a negative nasogastric tube aspiration that's negative for blood. So the treatment options now are depending on the source of bleeding. I came to conclude that I can order P's. It could be pharmacological, endoscopic, angiographic, or surgical. For the non-variceal bleed, Since the topic is an overview, I won't delve into much details about others or this specifically, but we can always decide to choose each subject and then elaborate on it. It accounts for about 40% of the causes of non-variceal bleed. Of all patients with peptic ulcer disease, not all patients will bleed, just about 10 to 15% will bleed. But this 10 to 15% is an important percentage because it is the commonest cause of death and commonest cause of surgery. The, should I say, high cost of surgery used to be perforation, but with H. pylori control and then good pharmacologic control of acid secretion and gastric, PPIs and likes, the incidence of perforation has reduced, but that of bleeding is still surprisingly the same. So incidence of bleeding duodenal and gastric ulcers are similar. Yes, we have more duodenal ulcers than gastric ulcers, but gastric ulcers have propensities to bleed than duodenal ulcers, making the two almost similar in incidence. So for non-variceal bleed, PUD specifically, it could be medical, endoscopic, or surgical. In case of medical, next slide please, case of medical treatment, the proton pump inhibitors can be used. A typical prototype, omeprazole, and then you can use the histamine receptor antagonists, though they do not give absolute gastric suppression. So the choice is still the proton pump inhibitors. It would reduce the chances of rebleeding. So minus the fact that it's going to abate bleeding and give some advantage, the chances of rebleeding is also reduced, and it is part of the objective of managing these patients. You don't just want to stop bleeding, you also want to reduce the risk of rebleeding in patients with upper gastrointestinal haemorrhage. Helicobacter pylori eradication in the case of bleeding duodenal ulcer is a bit controversial, though it's possible in about 60 to 70% of cases, and where present, eradication would reduce the chances of rebleeding. And then you also want to encourage the patients to discontinue steroid anti-inflammatory drugs, selective serotonin reuptake inhibitors that would provoke bleeding. Of course, patients on anticoagulants or patients on non-steroidal anti-inflammatory drugs for other reasons that cannot be stopped would then have to be on close monitoring. Next slide, please. Yeah, for the endoscopic treatments, we have injection, we have mechanical, thermal, combination of the two, and then clips. For injection, commonly used is epinephrine, 1 in 10,000 dilution. It has been shown that injecting about 13 mils of epinephrine solution offers better hemostasis than using just epinephrine alone, suggesting that there can also be a tamponade effect. Patients who use just epinephrine are likely to have a rebleed in 50% of cases, and as such, use of epinephrine should be combined with other methods. There could also be a mechanical method and thermal method. The thermal method could be electrocautery, monopolar, bipolar, use of lasers. Recently, we use the APC, the argon plasma coagulation. Combination therapy, case where you would inject and then use electrocautery, will be successful in 90% of cases. The use of clips is not too important, except when there is an obvious bleeding vessel that you can catch for obvious reasons. So the surgical management now, about just 5 to 10% of patients will require surgery. Indications are spelled out for surgery in bleeding PUD. They include 1, a patient that is refractory to resuscitation. What do we mean? This patient is still having hypertension despite receiving as much as either 4 packed cell units of blood or 6 units of whole blood. Patient that is having persistent bleeding despite resuscitation or despite endoscopic management. Usually, 2 attempts at endoscopy is acceptable. Patient that is having another recurrent bleeding despite arrest of the first bleeding is an indication for surgery. A patient that is also having continuous small gastrointestinal bleed, by definition of patients requiring about 3 units of blood per day in order to sustain blood pressure. Those are surgical indications for patients with PUD or non-variceal causes of upper gastrointestinal bleeding generally. But other factors that we can also consider include the size of the ulcer. Ulcer that is more than 2 centimeters in size would likely require surgery. The position of the ulcer, posteriorly located ulcers due to the risk of vessel invasion. The type of the ulcer, the chances of surgery with gastric ulcers is higher than that of duodenal ulcer because they have the propensity to bleed and there is concern for malignancy. Patients who present in shock and patients with a low packed cell volume. All right, so duodenal ulcer, the aim of control is to secure hemorrhage. Depending on the surgeon's preference, level of expertise, and comorbid condition of the patient, other procedures can be done. But the aim of surgery is to control hemorrhage. Acid-reducing procedures for bleeding duodenal ulcer is controversial. It is not for perforations, but for bleeding is controversial because it has been shown that with H. pylori eradication, the chances of recurrence is also low. And H. pylori with non-steroidal anti-inflammatory drugs have synergistic effect. So the question is, if you can eradicate H. pylori and there's reduced chance of rebleeding, is there still need to have an acid-reducing procedure for bleeding duodenal ulcer? But historically, a pyeloplasty is usually done plus truncal vagotomy. For gastric ulcers, the risk of rebleeding with just suture ligation is 30%. Excision of the ulcer is usually done because of a 10% risk of malignancy, but is also associated with a rebleeding risk of 20%. So we can decide to do a number of things. A distal gastrectomy could be an option. Excision and primary closure could be an option. And if the ulcer is located close to the gastro-oesophageal junction, the distal gastrectomy with a tongue excision involving the ulcer can also be done. But those located close to the gastrointestinal junction are quite difficult to control. And then for variceal bleeds now, the varices occur as a result of dilated submucosal veins due to portal hypertension. Commonest cause is liver cirrhosis. It could be schistosomiasis in some places, and then thrombosis, and so many other causes actually exist for portal hypertension. The degree of bleeding, yes, correlates with outcome in patients, but it has been shown that mortality in patients with variceal bleed is also very dependent on the severity of the liver disease. A patient could actually have massive bleed and not die from it because it still has some hepatic functions, maybe a triple score of maybe class A. You can't compare the same patients in terms of outcome or chances of dying with a patient with a triple score class B or C. The risk of mortality in 6 weeks with a variceal bleed is estimated to be about 20%. So the next slide shows pictures showing us this esophageal varice. It should be a smooth wall. Different grading system also are applicable for esophageal varices. Some just thin streaks, not visible. Others, that is the varices are not extending into the lumen, some call that grade 1. If it protrudes into the lumen, some call that grade 2. Grade 3 is when you have variceal swellings around, but there is an intact layer of mucosa between. And then for grade 4, when there's no intact layer of mucosa. Some also grade it by saying varices noticed on inspiration for 1. Varices noticed at any phase of inspiration, whether inspiration or expiration for grade 2. Of course, with inspiration means just increasing, it's just vasava maneuver. And then the grade 3 being varices involving just the lower esophagus, and then grade 4, the entire esophagus. So I've seen various grading systems for that, whichever you choose to follow. So the slide just beside it is showing us the band ligation. For variceal bleed, just like the non-variceal bleed, we could also have medical treatments, endoscopy, shunt surgery, devascularization, and of course, in a case of liver failure, liver transplants. Most of these other procedures we also do are not temporary measures. They are just, they are not permanent measures. They are just temporary measures. And then the role of a balloon tamponade is a mechanical therapy. It is just in the interim. You don't use it for more than 24 hours. In fact, there's risk of esophageal necrosis when the balloon stays for more than 12 hours. So for the next slide, please. Yes, this just is a sensitive Blakemore tube. It has a gastric balloon, it has an esophageal balloon, and then it has a port where we can actually aspirate contents. The aim is to inflate this gastric balloon with about 50 mils of air. It is discouraged to inflate with oily substances or fluid. To inflate 50 mils with air and then adjust so that it will be at the gastroesophageal junction, and then we inflate further with extra 250 mils to make it a total of 200 mils. And for the esophageal balloon, the target pressure is about 40 millimeter of mercury to secure hemostasis. Removal of this would, of course, provoke bleeding in 50% of cases. It is just a stopgap between failure of endoscopy and medical therapy and surgery. This patient has not responded to endoscopic therapy, is bleeding. We want to buy time, we can put in this tube, pending the time patient is being worked up for surgery. Other tubes include the Minnesota's tube. So next slide. For the medical treatments, we can classify the drugs that we use for variceal bleeds into drugs that cause splanchnic vasoconstriction, vasopressin, telepressin, somatostatin, and octreotide. Octreotide is the drug of choice. Vasopressin and its analog telepressin, yes, they do a wonderful job of causing splanchnic vasoconstriction, but it is also known that it could predispose to myocardial ischemia and infarction. So in a case where you are trying to save the patient from bleeding due to portal hypertension and then you knock off the heart, you don't want to find yourself in such situation. And then octreotide can be used. For vasopressin, they could also administer to nitroglycerin just to avert the side effects on the heart. But like I said, it's octreotide as the drug of choice. For vasopressin, about 0.2 to 0.8 microgram per minute is given, pending the time patients can have other procedures. And then for octreotide, we want to give 50 international unit bolus, and then give 50 international units per hour in infusion. And then we also have drugs that reduce portal vascular resistance. Non-selective beta blockers are examples: propranolol, nadolol. We can give 20 milligrams of propranolol, BD, nadolol 40 milligrams daily. These usually are in the, should I say, chronic phase of management, not usually in the acute phase. In the acute phase, what we want to do if the patient comes with variceal bleed is we want to resuscitate the patient, we want to pass an NG tube, we want to assess for risk or possible need for ICU admission, we want to start octreotide, and then attempt endoscopic therapy, which could be in form of sclerotherapy or band ligation. And if that works, we move to the next, or if that doesn't work, we use a stent ECMO tube and then prepare the patient for surgery. So for sclerotherapy, we have paravaricial bleed, we have intravaricial bleed, or combination of both. Paravaricial bleed just means giving around the varices. For paravaricial bleed, we could use as much as 10 to 15 mils of our sclerosant. Intravaricial, where we give into the varices itself, comes with a lower dilution, and we can use a combination. Common sclerosants that are used include ethanolamine oleate, include sodium tetrabenzyl sulfate. We also use sodium morate and alcohol, amongst others. So we can also do an endoscopic band ligation. Sorry, I put the picture just beside the Oesophageal variceal picture that I earlier projected. Maybe after the presentation, we could see that again. Yes, this is it. So this is just band ligation. Of course, band ligation would not be possible in maybe grade 1 or grade 2 because there's actually nothing to pick for you to apply a band on. And this band ligation is actually a continuous process. Let me put it that way. You want to put a band ligation. You want to reassess the patient for a repeat endoscopy. You want to do that in about, then some would say 1 or 2 weeks. Actually, I see as 10 to 14 days. And you want to continue this process until you have complete ablation, or should I say occlusion of these varices. You do for this first, you do for next. And then you want to repeat endoscopy at 1 month, 3 months, at 6 months respectively to assess or prevent the bleeding. So it's like this. And then shunts too. Shunts are temporary measures. They are actually, it's worthy of note that patients with portal hypertension, bleeding is just one of the presentation. Patients could have a cephalopathy, could have refractory ascites, could also have hydrothorax. So these tips and some of these shunt systems also help in control of ascites, refractory ascites, especially for tips, and some surgical methods of shunting. For the tips, it is actually the commoner of the procedures done now, except maybe in developing countries where facilities for tips are still not available. And for so tips is just about shunting. We are putting a stent between the portal vein and the hepatic vein so that we could bypass that was a portohepatic shunt under image guidance. We could also do or perform the surgical shunt method, or surgical shunting system. It could be non-selective, selective, or partial. Non-selective means that we are diverting all the blood into the IVC. Blood is not moving from the portal vein into the liver, into the hepatic vein, and then into the IVC. We are shunting the blood directly from the portal vein straight to the IVC. This predisposes patients to encephalopathy. So non-selective procedures would usually have risk of encephalopathy. Selective procedures include the Warren shunt, the distal splenorenal shunt. We still have some blood going into the liver, and then the chances of hepatic encephalopathy is reduced. And then for partial shunts, they are for shunts that are less than 10 millimeter in diameter. Of course, there could be complications with tips. Chances of stenosis are there, and chances of thrombosis are also there. The chances of stenosis are usually due to neoproliferation of the cells of the intima of the vessel, and it's commoner than what you have for thrombosis. Tips after insertion requires follow-up. The interventional radiologists have a role to play here. Without follow-up for tips, so this is just it, we're just trying to bypass this, is that without follow-up, the chances of blockage or the chances that this would remain patent is just can be as low as 25% to 65%. So it's a wide range, yes, but taking the lower limits, this can be as low as 25%, but with follow-up, that can be reduced to 85%. So the next slide just shows the different surgical modalities of shunting. Okay, we can do a side to side. So this is the portal vein. This is the superior mesenteric vein. This is the splenic vein. They come together to form the portal vein. So we are making a side to side portocaval anastomosis here. This is the same, just that it's end to side. Mesocaval just means that you are taking the mesenteric veins and joining it with the IDC. And then this is a distal splenomesenteric shunt, otherwise known as the Warren's shunt. This is known as the X shunt. There are various names for the shunts, but I'm not going to bother with this. Sorry, the next slide. Then we could also have a devascularizing surgery. Instead of shunting, we want to transect the esophagus and then transect all forms of connection with the portosystemic system. A typical example is the Suburia procedure. Of course, it gives very good hemostatic control, but it also has a high mortality rate. And then liver transplant. So usually we shunt patients that are waiting liver transplant. Questions may arise that which do you do? Do you want to do a TIPS or you want to do a surgical shunting system? A general, of course, this is not absolute, but the general way of looking at it is if transplant is going to occur in less than 1 year, you do a TIPS, and if it's going to take more than 1 year, you want to do a surgical shunt because of risk, like we earlier said, of the TIPS getting stenosed or thrombosed as opposed to the surgical shunting system. So that's the brief overview about the presentation and the management. For the challenges, yes, in this part of the world, we have very poor referral systems. You are seeing patients, and because you think this upper GI, I'm not a physician or a surgeon, people tend to be lackadaisical about the referral of patients with upper gastrointestinal bleed, or they simply say, oh, it has stopped, you can go home. There is room for assessing the risk of rebleeding in these patients, which could also tell us about the outcome in terms of mortality. So poor referral system is still existing. We have this gap of a lack of emergency specialists in training. Nigeria, for example, we don't have emergency specialists. We just have maybe resident medical officers or clinicians or surgeons manning the emergency. They're actually medical emergency specialists who can be trained to do this. And it is actually the work of the emergency specialist to resuscitate the patient adequately. And as earlier highlighted, there were some clear-cut indications for surgery. So calling surgery first does not mean surgery is not going to save all the physicians, but there is more to be done at the emergency level, which could change the outcome in this patient. We also lack protocols and guidelines in the management of these patients. And where guidelines and protocols are in existence, they are not being reviewed. What do I mean? I'm having my posting now as maybe the surgical resident in the emergency, and I'm coming across an upper GI bleed, for example. If I already have the protocols, maybe clearly written that I have to resuscitate, give so amount of fluid, give so amount of blood, check this, and that. If it's forest curve, this is what I need to do based on the large forest curve. This patient needs an endoscopy. We are able to plan ahead. We are able to start vasopressin, as in the case of, or I prefer autotype now because of the obvious problems with vasopressin if it's variceal bleed and NSAIDs. So there are no protocols. So it's about what you know, and then seeing the patient first with lack of some of these things may actually cause a lot of problems, or maybe in handing over process, the person who's taken over for you doesn't know what to do because there are no protocols, there are no guidelines. And this also tells us about the next phase, the attitude of patient is not probably my patient. This is a surgical patient, this is a medical patient. And very, very importantly, well, luckily I was able to come across an article this evening that stated that elective endoscopy services is not just a problem of the developing countries, that in places like the UK, emergency, they call it out of our endoscopic services, could be as low as 48%. And in patients who require endoscopy, sorry, I forgot to add that for patients requiring endoscopy, the standard is to have it within 24 hours. Early endoscopy can be argued by saying within 6 hours of presentation, patients can have an endoscopy. But in cases where patients are not stable and there's still ongoing bleed, there could be risk of perforation, and there could be problems with visualizing the actual point of bleed, mediastinitis amongst other things. But in this part of the world, endoscopic services are purely elective. Patients come from their house, maybe for suspected peptic ulcer disease or maybe a gastric tumor. They are ready to scope, take biopsy, and go. Endoscopy far supersedes that. There should be emergency endoscopic services like we highlighted based on the endoscopic severity scoring systems and even the clinical systems. By the time you start having some scores, you want to do an endoscopy. And then there should be a place of therapeutic intervention for endoscopy. Of course, the coordinator is in radiology, so I can always chip this in, that the role of the interventional radiologist is also very important. Tips, they come in, and in the cases of angiographic embolization, they also come in. So the solutions to some of these challenges are just the opposite of the challenges. We want the college to perhaps incorporate emergency training where they are known, training of medical staff. There should be protocols and guidelines for management of cases like acute upper GI bleeding. It should always be seen as an MDT, multidisciplinary therapy, where the role of everybody is important, from the first contact to the emergency surgery, to the clinician, the surgeon, the endoscopist, the interventional radiologist, the nurses, the anesthetists, so many, because some of these patients would actually come with comorbid conditions that may make anesthetizing the patient a problem. The patient comes in heart failure. Some anesthetists will say heart failure is a contraindication, absolute contraindication to general anesthesia. So these are things that I think we need to discuss early enough. And then the availability of endoscopic procedures. In conclusion, acute upper gastrointestinal bleeding is an important health problem. Multidisciplinary therapy approach cannot be overemphasized, and a lot of work still has to be done in our healthcare delivery system to improve the chances of survival in these patients. So thank you.
Thank you very much, Dr. Ridwan Adegboyega. I want to first of all apologize for the earlier hitch that we had in the course of this presentation. I'm going to make the slides available for us to go through at the end of this presentation. I want to believe everyone will have learned one or two things from what Dr. Ridwan has given to us. For example, upper gastrointestinal bleed can be very, very scary. And just as he has said, we need to take it as our own responsibility to ensure that the patient is adequately resuscitated, because the first contact of a patient presenting with upper GI bleed actually determines a lot. And most of the time, it's actually a general practitioner or a medical officer that will come in contact with these patients. And whatever they do to the patients will actually determine the final outcome on the long run. So I'm going to take comments, questions from our audience. Okay, Dr. Oluwega was asking if we can see the face of very good. We have our father. I just got the information now that our teacher and our father and a mentor to most of us while we're back in the medical school days and even during residency program. I'm not in surgery, but anytime I see him, I always want to be somebody like him. And then that is in the person of Professor G. Rahman. We are very glad to have you here, sir. Sir, we would like to hear from you, sir. Can you please unmute? We'd like to hear from you, sir.
Thank you very much. Thank you very much. Thank you. Sorry, I joined late. I did mention that to Dr. Adegboyega. I had another engagement, and I said I would try and join later. But the bits I was able to meet, I think I enjoyed the presentation, and I've also gained a lot from that. And I think this is a very good forum, and we should encourage such activities because it will always help us to improve on what we are doing at all levels.
Yes, sir.
So it's good to be with you this evening. Thank you very much.
Thank you very much, Prof. Once again, I'm very happy to hear your voice. And please, I would just like to quickly chip in that anytime from now, we might have to be also coming to you to learn more, to call for you to come to this platform. The platform is actually, it's the Doctors Assembly, and then we have medical doctors on the platform who wish to give the practice of medicine a new face. We want to carry out that your dream, that your aspiration of making medical practice top-notch, despite the limitations we have in this part of the world. So that is what we're actually doing. And then the virtual assembly that you joined tonight, sir, is actually a move to ensure that we improve ourselves, not only academically, but our lives, our social life, our academic life, our practice as medical doctors. So once in a while, we might be coming to you, sir, to also invite you to the platform to learn more from you, sir. I'm very, very glad, and it's a very big pleasure having you on this platform, sir. Thank you very much.
Thank you very much. Thank you. Thank you.
So do we have any other comments? Okay, so in the absence of no comments, please, if you check the participants, the presenter is already sharing his video, and he's using his phone touch light to show his face. So for those who wants to see the face of the presenter, that's Dr. Ridwan Adegboyega. Is just as I've said, and then you have also seen that is one of our best in the 2014 set. That's the Mirrors Eminentis class of 2014. So thank you very much. It's also a pleasure to have all of you on this platform. By April, our April virtual assembly will be hosted by the pediatrics, the faculty of pediatrics. And I can assure you it's going to be another wonderful presentation. For those who couldn't join us, this presentation will be on our YouTube platform for us to listen to it again later, maybe sometimes early next week by the grace of God. So once again, I want to say a very big thank you for to all of you for making it a date with us. Do have a nice day. Good night, everyone. Bye-bye.
Good night. Bye-bye.
Good night, sir.